Hello, my name is Dan Scarpelli, and today I'm going to talk to you about epilepsy. When we talk about epilepsy, there's often some stigmas that are related to it, seizures being one of them. So um, let's be clear and say that epilepsy is not a specific disease. It does not come with strings attached every single time. You might not know what you're getting into when you're diagnosed with epilepsy because it's such a broad spectrum. It's often considered a spectrum disorder because of its different courses and types and severities that it takes on. We've known about epilepsy for a long, long time, but only for the last century or so have we really been able to understand it, and it's just a matter of understanding different seizures that happen. Seizures are categorized into two groups, focal or partial seizures and generalized or primary seizures. These seizures are based off of or are categorized by the individual's appearance and how they're acting during the seizure as well as after the seizure, and can also be linked to the electrical activity in their brains while it's happening. So focal or partial seizures are a little less dramatic, and they originate in only one part of the brain, and they target about 60% of the people diagnosed with epilepsy. And when we talk about the more primary or generalized seizures, we talk about the convulsive seizures, the very violent ones where you see people shaking and moving around, and just a little bit more noticeable than your focal seizures. And when I say they're not noticeable or less noticeable, sometimes they're not noticeable at all. They can be described as absent seizures where nothing is happening at all. You know, the person looks like they're daydreaming or just staring blankly and off into the distance. They can have isolated movements where just one arm or a hand or part of the face is shaking, or just the lips, and it's just not as distinguishable as your generalized, which we'll get into in the next slide. These focal seizures can cause sensations as well, without any signs. These people can be completely conscious, moving around, and get an intense feeling of fear or elation, or have longer bouts of deja vu. They could have stomach pain or unpleasant smells that are affecting them, and these feelings are called auras clinically, and their auras may precede generalized or convulsive seizures a lot of the time. So a lot of the time these focal seizures can be used as a red flag to track down a generalized or a primary seizure. They happen before them, so when a patient knows they're having a partial seizure, they can alert somebody or alert themselves and get it under control before we have a generalized or grand mal seizure, which is a full body spasm. There's loss of consciousness often accompanied with it, and sometimes loss of bowel control, which is not to be expected sometimes. Individuals who experience these convulsive seizures, sometimes bite down on their tongue and cause bleeding. That comes with, stiffening muscles, in the face, oftentimes in the back, jerking movements with the limbs, just complete loss of control here. So some of the causes that we see here are electrical, but can be some withdrawal problems. Alcohol is a big one. Brain inflammation, head trauma, tumors in the brain, anything that can disrupt this electrical flow that needs to be disrupted to have seizures occur. You can have an infection in different areas of your body that can cause these things. Genetics often get raised. Genetic mutations play a huge role in developing epilepsy by affecting imbalances inside your body. Oftentimes genetic mutations in brain ion channels in different parts of the body. Ion channels, they push through these different chemicals that need to be pushed through to have the wiring work well. And sometimes these imbalances are found and cause disruption all over the body and can cause you to have these seizures. So when we look at these seizures, we want to find out if they're epileptic, if they're non-epileptic, or if they're provoked seizures. Because if they're epileptic, then you need to diagnose and treat them with medications. Non-epileptic seizures need to be diagnosed, and the other physiological condition or muscular disorder that is causing these seizures needs to be found out. Or if you have a provoked seizure, you need to find that out too, because it could be a cause of a withdrawal from drugs, or a blood sugar imbalance, or you were diagnosed this drug and after you stopped taking it you started having seizures. Provoked seizures are sometimes one and done, two and done. They usually don't happen again once the problem that is causing them has been fixed. So when you talk about a trigger, which we're going to talk about next, it could be a provoked seizure that the trigger wasn't necessarily brought to light like these other ones could be. Some minority of people with epilepsy have triggers, and some of these triggers are loud noise or loud music. Flashing lights are often attributed or often contribute to the stigma that is epilepsy. Strong emotions can trigger an epileptic seizure. Whether those emotions be good or bad, stress is a huge one. And when we talk about exercise later, we'll talk about stress. Now, after the seizure, a patient might be, or an individual might be, extremely confused. They might feel like, they just got hit in the head. They have a throbbing, sore headache. These symptoms can last for minutes to hours, depending on the individual, and sometimes, the lines might be blurred on whether they know exactly what they're talking about or what they're experiencing. They may be experiencing weakness in their arms and legs. They might have temporary sensory loss. They might lose vision. They might have difficulty speaking or knowing where they are. All of these evidences are crucial in diagnosing the type of seizure that is being dealt with and what part of the brain is really being affected. So when we look at children, when we're diagnosing them, parents often become very alarmed. They kind of freak out. So a clinician will calm the parents down and let them know that just because you have a seizure does not mean you're epileptic. Oftentimes clinicians require a child to have 2 or more seizures before diagnosing them to really figure out what's going on with this person. Is this a provoked seizure? Do they have a head injury? Have they been taking a drug that could cause it after withdrawal? Have they had a fever? Fortunately, most seizures can be controlled with a medication, but rarely do you want to just jump into medicating it immediately. You want to figure out what's going on first. So you're going to test the child. During testing, you want to do a complete physical exam and have a blood testing done and move on to the EEG, which measures electric brain activity and is used to search for abnormal electrical activity in the brain that is commonly associated with epilepsy and the seizures that the person is having. And it allows for the doctor or the clinician to have a clearer understanding of why and where these seizures are occurring. And oftentimes they ask their patients to keep a log so they can get a perspective on what they're seeing as the person going through the seizure and have a deeper understanding of what happens to them. Adults are a little different. A lot of adults who are diagnosed with epilepsy have a lot of loss of independence. It's a life thing. You have impaired self-confidence. You can't really be trusted to drive. You have a higher risk of falling and hurting yourself. So about 1% of people over the age of 65 are diagnosed with an epileptic disorder. And annually, this incidence of epilepsy rises with each decade over 60 because the disorder is frequently underdiagnosed at this point. So when we test, we want to be thorough because there's so many different kinds of epilepsy someone could have. So we want to do, for adults, we want to do a lumbar exam or a spinal tap to see if they have infections in their spinal fluid or bacteria in there, or sometimes an abundance of white blood cells. And then you would move on to MRI or CT scans to get a check for tumors or a stroke, or see the structural brain in that patient to see what's really going on with them. After we get an overview, we want to treat this with medication usually. Patients with epilepsy often take more than one medication, and it takes a couple medications until they figure out which one's the best for them. And by best, I mean you're protecting them, and you're also reducing the severity of the seizure. And usually you want to meet with your healthcare professional regularly and start at a low dose and slowly increase it. Most of the patients try multiple drugs before finding the one that works for them best, and these things have side effects. You can't just rush into multiple anti-seizure drugs to treat someone with epilepsy without seeing which one is going to affect them least. So we have the side effects of these drugs are sometimes becoming suicidal or wanting to hurt others or harm others, or we have something like Stevens-Johnson syndrome, which is a fever accompanied with painful blistering rash that kills the top layer of skin on somebody. And it's usually common when taking a certain couple of drugs, and it's likely to occur within 2 months of taking the prescription. So these are things that you want to take baby steps when talking about medication with epileptic patients, because it can get real sticky really fast. So for my exercise prescription, I wanted to look at a young male who is epileptic and is generally pretty healthy, as you could see. He has no history of cardiovascular diseases or anything. He's a non-smoker. His BMI is 25, and when I did some research on this, it seems that aerobic exercise is huge with people with epilepsy. You should get them working 3 to 5 days a week with sessions that last up to 40 minutes. If they can't complete 20 minutes of ongoing exercise, you can do smaller bouts with them at smaller times, and you should get their work rate really up there. You should get them moving and break up the carbon dioxide concentration inside the body. You should get oxygen in there flowing. Strength training at first should start with low weight, high reps, and should progress with the client telling you how they're feeling. When I first began training with someone, I would restrict them to just machines, just in case an epileptic incident did occur, so that if they were using a free weight, it wouldn't fall and harm them. Unfortunately, persons with epilepsy have been discouraged from participating in physical activity because they've been told that it's going to increase seizure frequency. However, studies show that people with epilepsy can undergo the same exercise as people without it and really have the same benefits that people do. So I would take it slow with someone with epilepsy, but I would definitely encourage them to get out there and get moving. That's what I have to present on epilepsy, guys. Thank you for watching, and I hope you learned a little.